Hello, everybody. Welcome to Tuesday edition VMR, where we have myself and we have my great friend Kirtan, who will be co-discussing today. And we have a case from Shreya today, who will be presenting a wonderful case, and also scribing by Seema and teaching points. We have Manaswini and Sire that will be helping us with both of um, um, these parts of the VMR. Hope everybody is doing well today. I'll swing the mic over to Kirtan to see how things are today. How are you?
Perfect, Dr. Singh. I'm good. Thank you for introducing. Excited for the case as always. And friends, feel free to share your thoughts in the chat. And Dr. Singh was telling me earlier before the meeting started that maybe we will plan to do a breakout room at some point in this session so that everyone gets a chance to intermix their thoughts. And then we will come back and we will decide when we can do the breakout room. So excited to be here. And now maybe I can pass the mic to Shreya, who is presenting case to us.
Sure. Hi everyone, I'm Shreya. I'm back again presenting a case in CPS as I always love to do. And yeah, I'm looking forward to this session.
Perfect. Yeah, we haven't seen you in a while, Shreya, so thank you so much for coming back. And this is the best way, right? You're presenting a case, so thank you. And now I can pass the mic to Simi. Simi, how is your day going so far?
Hi everyone, it's night time for me and very excited for Shia's case and discussion by Kirtan and Dr. Ravi. So very excited to scribe today.
Perfect. Thank you, Simi. And then I guess Sai is helping with the teaching points. Sai, how are things with you today? Oh, I think Sai, you might be muted.
Sorry for the disturbance. Hi, my name is Syed. I am doing teaching points today. Um really excited for the case.
Perfect. Thank you. And then finally, Manaswini is also helping with the teaching points. Manaswini, how are things with you today?
Uh, Everything's good. Excited for the case and the discussion.
Perfect. Awesome. Well, Shreya, whenever you are ready, let's get started.
Okay. Do we have our whiteboard? Okay, I'll start then.
Yes. Yes.
So yeah, we have a 44-year-old male with previous history of orthostatic hypotension presenting with a worsening dizziness now. And I'll stop here.
You want to take a first stab, Kirtan?
I think Dr. Singh, you can go first this time.
Yeah. Okay. I usually have the guest go first, but this is a good opportunity to take a first stab at what's going on. So what's interesting here is the patient's age of 44 years of age, close to 50. We would say, yes, this is the age of transition where certain conditions can rear its ugly head, certain things such as vascular disorders, maybe some organ-related disorders, endocrine-related disorders. Above 50, we do tend to have some malignancy associated disorders. They don't span the length and breadth of a lot of this age-related conditions, but we do kind of have an association of conditions here. So we have a backstory of orthostatic hypotension with this patient. So 44 years of age, it's interesting. Usually orthostatic hypotension, let's say it would be a dysregulation of the autonomic nervous system where the signals are not compensating against gravitational changes in the patient's maneuvers. So when the patient is maneuvering against gravity, then the receptors kick in and then increase the heart rate, vasoconstriction to maintain perfusion to the cerebral centers of the body. So here the patient has orthostatic hypotension, maybe due to autonomic dysfunction. But the other flip side of the coin could be a volume related disorder. So this would be where you would have a lack of volume, which isn't just fluids, but it could also be blood. So if there's a deficiency in any of these, say the patient gives you a history of the next aliquot, Shreya mentions that, oh, this patient had nausea, vomiting for like 5 days. You pretty much have the diagnosis there that there's volume deficiency. However, if the patient says, I've been having bleeding for several days, there you know it's a blood-related issue rather than a volume issue. So, with the background story of orthostatic hypotension, now comes this worsening dizziness. Is this dizziness related to this condition? We don't know. But definitely, I think my first, okay, testing before we even get to labs and imaging, the first testing you would do would be vital signs. You would do an orthostatic maneuver to see if there's a drop in the blood pressure. Long ago, we actually used to look at the pulse as well. So an increase in the pulse and a drop of blood pressure. But now it's been reduced to just the drop in blood pressure would signify orthostatic hypotension. Once this is positive, it pretty much negates having to go even to higher levels of workup, complex testing. You would try and remedy this by saying, is this a volume issue or is this a blood issue here? The dizziness could be a new symptom, and that's where I'll bring Kirtan in, because dizziness by itself, orthostatic hypotension, you feel lightheadedness and you would fall down, right? A lack of perfusion to the brain. Dizziness would be, I'm standing, I'm fine, but I'm like everything kind of swirling around me. So that sensation is very awkward. I'll swing the mic over to Kirtan to do a deep dive into this world of dizziness.
Perfect. No, awesome start, Dr. Singh. Like what Dr. Singh emphasized is that firstly, that this person has a history of orthostatic hypotension, and given the age of the patient, it's a little bit unusual, right? So we need to verify first that does this person indeed have orthostatic hypotension, or was it just mislabeled as hypotension, right? Because the strict criteria for orthostatic hypotension needs to be met in order to tag someone as orthostatic hypotension. Another important point is that if it was a real diagnosis, what were the interventions done at that time, and how long ago this happened, right? And then again, Dr. Singh mentioned, right, that we have dizziness, which is a new symptom. Now, should we try to link it to the orthostatic hypotension, or is it a separate problem? So we don't have enough data yet. And that's why we have to keep our minds open and not trying to fit everything together. We have to evaluate each and every component of this presentation individually, right? And similarly, when we hear the word dizziness, in medical textbooks and in real life, even in patients' notes, in like electronic medical records, you might have seen these terms being used interchangeably, right? Like dizziness, lightheadedness, giddiness, vertigo. What does it even mean, right? So it's very important to understand what it actually means and what are the physiological implications, because sometimes these sensations are so unusual. And I could say, like from my personal experience as well, that sometimes, let's say you had a like travel in the plane for like many hours, and then when you get on the land and when you are walking, sometimes you just feel uneasy. And if someone asks me at that time that, hey Kirtan, what do you think you are having, I don't think I would be able to put a name on it. Like, I don't know what is dizziness, I don't know what is lightheadedness. So you could imagine how difficult it might be for the patients themselves to even describe what's going on. At the best, they might just say that they are feeling uneasy, right? And you have to kind of accept the fact that you cannot sometimes get the clarity on these things like dizziness, vertigo, all those things. So that's why we try to find a physiological consequence of what is going on with them. So, for example, this person can have dizziness, lightheadedness, but if they are falling frequently, then you have something robust going on and you can put your attention to that. If this person has, let's say, associated hearing loss and dizziness, then you try to focus on the hearing loss, right? So sometimes that is how this exercise goes, that no matter how hard you might try to clarify, you may not get an answer. And that's totally fine. You try to figure out what else is going on with this person, right? So we will see from the HPI and the review of system that what is the background of this patient. Does the person have any inherent susceptibility to certain kind of disorders based on their genetic history, based on the family history, based on the social history, based on the medications which they might be on, right? So all those things will go in while we will be thinking about what is actually going on. So I think Dr. Singh set us up perfectly about what's going on. And then let's see what we see in HPI from Shreya.
This was an awesome start to this complaint. I will proceed further. So I don't have any information about his past history of orthostatic hypotension, like when was it diagnosed, how was it diagnosed. His attendant told us, and the patient had no idea about it. So yeah, uh, so he said he's feeling more dizzy than usual. He usually feels dizzy, but he is feeling more dizzy these few days. He couldn't say exactly how many days. And in the emergency department, he was hypotensive and tachycardic, and that's it. There is no. He reported no other symptoms, and there is no other complaint. In past medical history, he only has type 2 diabetes mellitus diagnosed, for which he used to take metformin. But recently, because of his poorly controlled diabetes, pioglitazone and glipizide was added. In social history, he works as a Nepalese army. He does not smoke, but he drinks occasionally. And I'm gonna stop here.
Well, thank you for giving this information, Shreya. So now we have a more context as to what's going on. So looks like that this person has been feeling really, really dizzy, and that's the only review of system we have so far. We don't have fevers, we don't have like night sweats, chills, so we don't have any constitutional symptoms to go on, and we don't have even focal symptoms which localize to one organ, like let's say chest pain, cough, shortness of breath, dysuria, abdominal pain, headaches, confusion. We don't have any of those symptoms. So we are primarily dealing with a problem which is just something wrong with the tone of the vasculature, right? Or maybe something is not present in the vasculature itself. So something is wrong with your blood itself. Maybe your volume is not enough. Or what Dr. Singh said initially, right? That maybe your autonomic tone is not enough to maintain the vasculature, especially when you stand up, right? Now, one key aspect we have to understand at this point in time is that there is difference between hypotension and orthostatic hypotension, right? By definition, every single person who is hypotensive might be orthostatic hypotensive as well, right? So it's more serious when you have hypotension than compared to orthostatic hypotension. Why it is more serious? Because in orthostatic hypotension, only when you are stressing your body, that is when you are standing up, something is going wrong. But when you are hypotensive, just like when lying down, which means things are really bad, that all the organs are not getting the enough perfusion. And we need to figure out that why this is the case, right? This person also has tachycardia, which means that body is trying to compensate for the to maintain the perfusion to different organs of the body. So which is a reassuring sign. And then we can see that how much tachycardia you have, whether it is appropriate or whether it is inappropriate, right? Now, in the review of system, we haven't heard anything which might suggest volume depletion. We haven't heard that if this person had frequent nausea or vomiting or diarrhea, but sometimes those things might be lost in translation. So it will be again a wise idea to go to the bedside and ask the patient again that how has been your intake in last few days? Like, are you eating and drinking less than usual? And are you utilizing certain substances which might contribute to nausea and vomiting or which might be contributing to diarrhea? So for example, like a practical pearl is often in real time. You might see many of the younger people who present with like such kind of volume depletion state and very undifferentiated syndrome. And they might not be forthcoming initially, but then when you build the rapport and when you ask them, they will say that, oh yeah, I have been using laxatives for past few months because I wanted to lose weight or something. And that's how you will figure out that, well, it is the excessive laxative abuse which was ended up causing such volume depletion, right? Similarly, someone might be utilizing diuretics like surreptitiously that they may not even say it and it may not be visible in their medication list, right? So asking about diuretics and laxatives, it's absolutely important, right? Similarly, any other substances, like are they using like any drugs? Do they smoke? Do they vape? Do they use marijuana or not? Because all of those things in its own unique way can end up contributing to the volume depletion or to the maintenance of vascular tone. So getting such kind of basic history is very important, right? Then second important thing will be to understand that is this the first time that patient is experiencing these symptoms or is this the recurrent thing, right? The third thing would be that what we said in the first report, that what are the physiological consequences? That this person is hypertensive and tachycardic, but are they having lack of perfusion to, let's say, brain enough to cause confusion, enough to cause any focal neurologic deficits like maybe blurry vision, right? What if they have inadequate perfusion to the skin? And when you see their skin, you feel that the pulses are weak, maybe the skin is cold, maybe the color of the distal extremities is like maybe cyanosed, right? Then similarly, what about the internal organs? That how has been the urine output? So we can ask this patient that how frequently you have been peeing. Do you think that over last few days you are peeing less? Then it would implicate that maybe the perfusion to the kidneys is also compromised, right? So this is what we need to do. That first we need to understand that what is the background in which this is happening. Like has the patient been taking anything? Has this happened before or not? And then look at the physiological consequences of what could be going on. And once we have kind of understood those problems, then we can try to think about other differential as to why this could be going on. Maybe for that reason, I will pass the mic to Dr. Singh to comment on the past medical history and tell us that what could be the possible reason this might be going on.
A wonderful discussion, Ketan. Yeah, I think you're painting the picture that you've painted is of a patient that I'm very worried about. Cold, clammy skin, lack of perfusion, and organ dysfunction secondary to low blood pressure. So this can actually result in many deleterious effects, right? So altered mental status, lack of urine, pre-renal azotemia, maybe ischemia to the organs, liver, cardiac, and so on. What's interesting, I think we both can agree we can maybe move away from the deep rabbit hole of dizziness and uh, peripheral causes, central causes, so stroke versus peripheral causes like the vestibular apparatus, BPPV, Meniere's disease, and so on. So I kind of was thinking about that. I didn't go into that space. But I think here what's really concerning is you don't just show up with hypotension. And you're right, the tachycardic, I'm not worried about the tachycardia. There's only one instance though where tachycardia could cause hypotension if you have a decompensated cardiac condition, right? So if you have an arrhythmia, say this patient has atrial fibrillation last week, POCUS, VMR, we had a patient with AFib with RVR with LVEF that was compromised. So when you have a decrease in filling times and ejection times or the systolic time, you will have hypotension. So I guess first question would be, what is this tachycardia? Is it causing this decompensation? Is the heart already in a decompensated state? Second thing is the tachycardia is it compensating for that hypotension? And how hypotensive is this patient? And when you go into the space of hypotension, a schema that usually we've sort of utilized the schema already. We talked about vasculature, right? So in the vessels, we have volume, we have vascular tone. Vascular tone, is there some deficiency in vascular tone? So certain conditions, you could have endocrinopathies like adrenal insufficiency. You could have maybe sepsis. Sepsis could cause this too, neurogenic shock, and so on. We have actually Yusuf is on here. He has a nice mnemonic for shock, which kind of has overlap to that as well. So that's the vasculature. Next is heart. So the heart is responsible for mean arterial pressure, right? So stroke volume, cardiac output. So is there any dysfunction in the heart? Where could the heart suffer dysfunction? So one could be the outlet from the heart, the valve, aortic stenosis, aortic regurg. So valvulopathy, cardiomyopathy, and anything in the pericardial sac like cardiac tamponade. And could there be an electrical abnormality going back to what we had hypothesized about the bundles and the electrical pathway of the heart? So we have the heart, we have the vasculature, we have then obstructive conditions in the lung, such as PE, and then I could kind of tag on to endocrinopathies, such as adrenal insufficiency, which can manifest in this method or in this way. That's sort of a rough overview of hypotension. And now we kind of have to figure out, like Kirtan had mentioned, is there any volume depletion in this patient? It will very well help simplify this problem that we have here if there is a history of it. So far, we don't have an history. The diabetes is interesting. Many of you have mentioned in the chat that with diabetes, autonomic neuropathy and autonomic dysfunction very much goes hand in hand with this. So I wonder if this is painting a background to this story as well. And nothing much else in the past history I can think about. You always have to consider about the drugs and side effects. Many times we've stumbled, we've kind of overlooked the drugs here, but something to think about and quickly then put into open evidence to see if any of these drugs could cause something like this. But I'm really interested if I have to push the needle forward with this case is definitely want the vital signs, and that will help us to determine which way to go. Is it maybe say there's a fever, we go into the sepsis category, say, or inflammation. If there's hypertension and low hemoglobin, we go into the bleeding category there, and so on and so forth. Any other thoughts, Kirtan?
No, Dr. Singh, that's excellent. And I will just like supplement what you finally said, that if we establish that this person has volume depletion and not the autonomic issue, then if you think about the volume depletion, then there are three ways in which you can lose the volume, right? Either through the GI tract, so nausea, vomiting, diarrhea, through your skin, or through your kidneys, right? Now, if you think about the base rate of the disease, which one of these is most likely to end up causing actual hypotension? It is usually going to be the GI tract, because imagine how much hard you will have to work out or how much dysfunctional your skin has to be in order to cause such profound volume loss that you end up getting hypotension. That is only seen usually in the setting of burns patient who might lose tons and tons of volume. But otherwise, in someone who has like normal skin and no obvious skin deformities, you should not lose that much volume, right? And same is true for kidneys. Imagine that how much polyuria you might need to have in order to actually cause hypotension. And that too, also, if you're not able to keep up with your volume intake, right? Like even if someone has polyuria, let's say they are peeing out 3 liters in a day, but if they're able to drink 2.5 liters in a day, they would be fine, right? So that kind of paints the picture, right? That as the base rate goes, we have to focus on GI, GI, GI. And only when we can't find a signal in GI, then we go to the kidneys. And I wanted to bring this up because what Dr. Singh was saying, right? Now it makes, it kind of adds to the perspective that this person has diabetes. We don't know how poorly controlled it is, right? We don't know whether it was type 1, whether it was type 2, right? And if someone has poorly controlled diabetes, you could easily imagine that they might have polyuria going on. Like, and maybe they even have ketoacidosis. And maybe because of dramatic polyuria, maybe because of that reason, they are volume depleted. And maybe they are not able to keep up with their intake as well. So that hypothesis we will have to entertain, and maybe the vital signs will kind of clue us if that is the case, polyuria mediated hypotension, right? And in realm of polyuria, in this case, since diabetes is there, obviously that will be the main suspect. But you also have to ask yourself that what are the other ways in which you might end up getting polyuria? So usually we talk about osmotic diuresis a lot. And in the osmotic diuresis, we talk about sugar a lot. But you often forget the salt. That salt-mediated diuresis is very common as well. And this is what happens in people who are on diuretics, right? So that is why, again, that point that we want to make sure that there are no diuretics involved. And then some other substances which you might be taking from outside, which might act as an osmotic substance or not. And then very rarely you can have insipidus, like diabetes insipidus. Maybe you're not able to hold on to any water, and maybe that's why you're losing tons and tons of volume in the urine. So that is the polyuria part. And then regarding what Dr. Singh was saying about medications, so we will have to see that what could be the contribution. But in general, if you think about it, the metformin is like just a routine drug, doesn't cause much with the volume issues. Pioglitazone is interesting because pioglitazone nowadays we don't use it that often, and it is one of those, how to say, PPAR gamma agonists. Basically, the whole concept is that it increases the sensitivity of the insulin to the end organs, right? But one of the notorious side effects of PPAR gamma is that it often contributes to actually volume overload because of the ability to retain the salt and water and cause like some vascular leakage. That is why pioglitazone is often known to exacerbate heart failure as well. So again, it will be interesting to see that what else this person could have had. Is it possible that, oh, maybe they have diabetes, but then they had other susceptibilities and they also have underlying heart failure, and maybe pioglitazone worsened that underlying state as well, right? So still the picture is hazy, as Dr. Singh said, and I guess with physical examination and vitals, we will be able to make more progress. So yeah, excited to see, Shreya, what you have for us.
Wonderful discussion and some awesome thoughts in chat as well. So yeah, I'm gonna give vitals and examination now. So we have blood pressure in the ED. Initial blood pressure was 90 by 60. Heart rate was 114. Temperature was afebrile, and respiratory rate was 24. On examinations, in CVS examination, S1, S2 hard, no murmur. GI was soft, non-tender, no organomegaly. Chest was normal. Neuro and MSK was normal as well. And after IV fluids were given to patient, vitals were BP 110/90 and heart rate was 90. So what do you think of this?
Kirtan, I don't know who was supposed to go first.
I think it's you, Dr. Singh.
Oh, okay. So what we were requesting, first of all, was the vital signs. See if there's any sort of pattern that we could utilize to decipher which of these hypotheses that we had discussed would be more likely. So as indicated earlier, tachycardia, heart rate's 114. So it's not significantly elevated to the point where an arrhythmia would cause cardiac decompensation. So at this juncture, I would kind of take that off the board at this time and put it on the back burner. And looking at the blood pressure, 90/60 and then 110/90. Was that with fluid, Shreya? Did it improve?
Yeah, it did
Okay.
improve.
So the patient is fluid responsive at this point, which is a great indicator. I kind of do like to track the blood pressure to see, because when it's a dynamic indicator. You give 1 liter of normal saline, say, and about 300 mLs of that pretty much stays within the vasculature. So actually the whole liter doesn't just occupy space within the vasculature for a period of time. So there is a sudden increase of the blood pressure. Then after half an hour, the blood pressure will change. So if you have a condition like, say, pulmonary embolism, the blood pressure will increase, then it will actually drop down again because you haven't removed the process, which is the driving force for the hypotension. So sometimes I could give you an indicator. If it is simply fluid depletion, the bolus will improve the blood pressure and it will stay at that level that it improved to. So I definitely would like to see over time how this blood pressure does respond. If it drops back down again, we didn't solve the problem. And then looking at the rest of the exam. So other indicators, so say, like Kirtan, we'd mentioned, we talked about anemia, right? So a good likelihood ratio, if you look at anemias, there is a good likelihood ratio to indicate anemia if you look at the conjunctiva and if they are pale. If you look at palmar-crease pallor, if you just look at the patient and see that they are just their skin tone is changed, that could also indicate anemia. So we have nothing here to indicate that there could be anemia. Anemia has to be significant if your blood pressure is like 90/60 or lower. So a hemoglobin of maybe close to 7, 8, 7, somewhere around there. There's no murmurs. We had talked about what about if there was a valvulopathy like aortic stenosis causing hypotension. So nothing here to indicate that. Even aortic stenosis can cause hemolytic anemia due to shear stress from the tight valve. So nothing here really interesting. It's just that the patient is fluid responsive. So we need to sort of shift gears to maybe thinking about other conditions that may be perpetuating this hypertensive response. My question also would be, did the patient feel better? Did this take care of the dizziness, or was he still dizzy with this correction of blood pressure? One last thing I want to mention is pulse pressure, right? So usually we mention that you have a narrow pulse pressure when you have volume depletion. In this case, that means the systolic and the diastolic will be closer together. When you have certain conditions like septic shock, they will be wide apart in this case because the diastolic blood pressure will drop dramatically in relation to the systolic blood pressure. So there's also something you can pretty much squeeze some extra diagnosis out of the blood pressure, see the difference between systolic and diastolic blood pressures. Here, they're not too off, so I don't think it indicates, again, volume depletion. I'll turn the mic over to Kirtan. Anything else comes to mind?
Yeah, Dr. Singh, like actually you are right that what we need is the test of time. We need to see that if this person responded to volume, but for how long, right? Because if you think about all the possible causes of hypotension, whether it is actually from volume depletion, whether it is something from some distributive in nature or autonomic dysfunction, like even sepsis, why do we give fluids in people with sepsis, right? So there are so many reasons we give fluids in sepsis, but the point is that fluids, even in sepsis, would cause your blood pressure to improve for a while, and only later it will be refractory, and that is when we think about pressors, right? So same is true for, in reality, any condition, because giving fluids bulks up your vasculature, right? So even if your vascular tone is not good, but since volume is good inside, you will respond transiently. So we will need to know from Shreya that firstly, whether the patient's symptoms improved, and if they improved, for how long they stayed like this. If these persons, you give them volume, and while they are in the hospital in front of you, and for one day whole, 24 hours straight, their blood pressure is normal, their symptoms are gone and they don't come back, then we can say for sure that, okay, this was volume depletion. But otherwise, if patient is fine for 1 or 2 hours, then again the blood pressure drops, then we are back to square one, right? Then we know that this is actually volume unresponsive disorder. So I think that is all I have to add, Dr. Singh, that we will need to see like how patient responded, for how long patient responded.
Okay, back to Shreya. After the labs, let's do breakout rooms.
Okay. Yeah, great discussion. And yeah, patient did feel better at this time now. So I'm going to proceed with some labs. We have hemoglobin of 6.9, WBC of 8,000, platelet was 3K, BMP was normal. In LFTs, total bilirubin was 0.7 with direct 0.3. AST was 28, ALT 32, ALP 92, calcium was 9, creatinine 1.2, TSH was 3.5, which is normal. HbA1c was 6, random blood glucose was 200, and fasting was 216. So I'm going to stop here and listen to your thoughts.
And Shreya, just wanted to clarify before Dr. Singh shares his thoughts, is that hemoglobin was low and platelets were also severely low, right? 3,000 only, right?
No, platelet is normal. I'm sorry.
Platelets are normal? Okay, all right. So
yeah, platelets are normal. Yeah. I'm
okay,
sorry if
so
I created
yeah,
confusion.
no worries at all. That's what I just wanted to confirm. And so only abnormality is low hemoglobin, right?
Yeah.
Okay, perfect. Thank you. Yes.
Okay, welcome back, everybody. Hope you had a wonderful time in each of the breakout rooms and got to discuss and partake in the diagnostic evaluation considering this patient. So anybody would like to unmute, maybe share a thought as to what they think is going on? I know I was in room 6. Fahid was there and he had a couple of good thoughts. Are you able to unmute, maybe share some thoughts?
You're too kind, Dr. Ravi. So I was in the room with Dr. Ravi and Hafsa, and we had pretty good thoughts. My initial concern was, should we base the entire chief complaint on the anemia itself, or is there another underlying process as well? But at this point, we have a great anchor to our case, and we can get to the diagnosis faster. Now, as a patient's bilirubin was in the lower range, I assume there is less probability for hemolysis here. So now it might be a problem of something related to the production of hemoglobin as such. And another point that came to my mind was that we have to rule out the GI malignancies as such in such cases with chronically low hemoglobin. And that's all. What do you guys think?
Oh yeah, absolutely wonderful. I think now we can make progress with this case just with that one lab value, which is the hemoglobin. Thank you for sharing your thoughts. And I heard Yusuf mention Sudarshan. You had some great thoughts. Would you kindly unmute and share some of your thoughts if you don't mind?
Yeah, of course. So what I was wondering was, so I have expected this patient to sort of have a HbA1c of quite higher than 6, and the RBS was also quite deranged. But since so what I think what I've learned is that if the hemoglobin values are pretty low, like in this patient, he's super anemic, the HbA1c is not going to be a good measure of the chronic diabetes that the patient has. So I think that's something that we should probably take a look at, but I don't know how much it would play into this case. But yeah, that was just something that I thought about.
Oh, very interesting. You're right. Yeah, about the hemoglobin A1C as well. So wonderful thoughts. Thank you, friends. That's absolutely marvelous. I think we now have possibly the reason, like Kirtan, we were looking for the what do you call it, the magic pointer to help us to navigate this case and get us to the diagnosis. So I think we pretty much have latched on to something. Any thoughts, Kirtan, before we go to the next aliquot?
Yeah, Dr. Singh, this is very intriguing, and we have to be careful at this point because if you think about it, anemia is a measure of hemoglobin in the body. And that is why people with anemia often have lightheadedness, dizziness, because their blood is not able to deliver enough nutrients to their CNS. But most of the people who have anemia, they have normal blood pressure. So we have to ask ourselves that this anemia is the cause of the dizziness and the symptoms, or something else is going on which ended up causing anemia. So imagine, what if I told you this person bled like 500 ml right now and then keeps on bleeding? Then that would cause hypotension and anemia as well. And then you would frame this as a hemorrhagic shock kind of picture, right? So still the details are murky. We haven't gotten enough hold of what is the clinical presentation in which this is happening. And is this new anemia? If this person's hemoglobin was 12 2 days ago and now it is 6, the picture is different than versus who had hemoglobin of 6 for like 5 years, right? So that is what I'm trying to understand, that what is the temporality of this hemoglobin? Is the person bleeding somewhere actively? And not just in the obvious sources, like if someone is having hematochezia, melena, hematemesis, you will see it. But what if it is an occult bleeding? What if patient is bleeding, like say in the retroperitoneum, or maybe in the lungs, or maybe in their muscles in some compartments, right? We didn't see anything on the examination. So the question becomes that if the person is indeed bleeding, where is the person bleeding, right? So still, I am not confident as to like what is going on exactly. Like the best thing which will help us right now is that what is this person's baseline hemoglobin levels, right? And when was the last time it was checked? That will be a very, very crucial clue as to figure out what's going on. And then, of course, the basic nutritional labs will be important to see like what is iron, what is B12, what is folate, and then basic like reticulocyte count, which can guide us whether the bone marrow is working or not. But I don't think that that will be able to help us much unless we figure out what is the baseline hemoglobin and what is the picture which I'm looking at, right? So that's what I was thinking, Dr. Singh. Anything else which you had in mind?
Oh no, marvelous job deciphering the acute versus chronic anemia. So here I think that you have proved a very important point. And yeah, do not invest all your eggs in one basket with this anemia basket. But let's do this at this point. Let's go to the next aliquot and see what Shreya has in store for us. Back to you, Shreya.
Awesome discussion. So yeah, I'm gonna give some more labs now. So we have iron panel, which is normal. MCV was 108.7. MCHC was 35%. LDH was 301, heptoglobin 10, reticulocytes were 20, PT was 12, PTT was 40, INR was 0.7, vitamin B12 was 600, and folate was 3.9, and homocysteine and MME was also done, which was normal. So I'm going to stop here and listen to your thoughts now.
Thank you, Shreya. And Shreya, just clarifying point that do we have a baseline hemoglobin for this person?
Yeah, it was actually done. Blood test was done 1 week back, and we had hemoglobin of 10 point something, 10.9.
So we know that this is like dramatic decline in 1 week,
Yeah.
right? Okay,
Yeah.
all right. And then another clarification point was that the heptoglobin of 10 in your lab, is that low?
It is low. It is very low. All
Okay.
the things are the standard units.
Okay, perfect. Thank
All
you so
good.
much.
Yeah.
Perfect. So I think, yeah, it's my turn this time. So, all right. So, friends, now you see that how much context helps you, right? And this is one of those very important concepts that imagine when you are reading a book or when someone is telling you a story, before trying to get to the end of the story, won't you ask basic questions like what, when, how, why, where? So, same is true when you're solving a case, that it's easier to latch on to some parts of the labs and trying to make the progress. And it does help sometimes when the lab is like very unique. Like if someone told us that, oh, this person's like alpha fetoprotein levels are 5,000, then okay, you can latch onto that and try to figure out what's going on. But when things are very hazy, like, okay, someone's hemoglobin is low, someone's LDH is high, which can have so many different causes, it's better to understand the story in detail. Right? So now we have a clear picture of a person who is presenting with acute dramatic decline in the hemoglobin levels. And this adds to our problem representation, right? Because now we can clearly say that, of course, if your hemoglobin drops by 4 points in a matter of few days, you will feel dizzy. You might not be eating as much, and maybe that contributed a little bit to the hypertension as well, right? So now our job is to figure out that why this person has such a dramatic decline in hemoglobin. And in general, you could imagine that the nutritional deficits, if they were causing anemia, it would not be so dramatic. Even if you stop eating right now, all the nutrients, you will still have enough stores in the body that it would not reflect in your hemoglobin levels in a matter of 7 days. So when you see such dramatic decline, there are only two main causes which remain. And same is true for bone marrow production as well. You could imagine that if right now your bone marrow stops functioning, let's say you have aplastic anemia, it takes a while for equilibrium to be established in the body. And aplastic anemia is not going to cause your hemoglobin drop from 10 to 6 in a matter of 3 or 4 days, right? So bone marrow production is gone, nutrition is gone. So what is remaining? That maybe you are bleeding somewhere and maybe that is causing dramatic decline. Or second, you are hemolyzing it. Because hemolyzing is in a way similar to bleeding, right? That you are just destroying the blood cells. When you are bleeding, you are just getting them out of your body, right? So now the question becomes that, have we crossed the threshold to label this as an acute fulminant symptomatic hemolytic anemia, right? And I think we have crossed that threshold. How can we say that? Because patients' heptoglobin levels are undetectable. And in general, heptoglobin levels are a very strong marker of hemolysis, because you could imagine that there are not many things in the body, like physiological processes, which will cause low heptoglobin. The only other scenario, apart from active brisk hemolysis, where you might see low heptoglobin level, is probably in cirrhotic patients, because heptoglobin is produced by the liver. So if someone has very end stage cirrhosis, then maybe the liver is not producing enough heptoglobin. But apart from that scenario, there are not many physiological processes which will cause such undetectable heptoglobin, right? So that is a very strong marker for hemolysis. And another important point, that although in med school we learned that indirect hyperbilirubinemia is a marker of hemolysis, but it is not sensitive. The reason being that your liver has capability to conjugate the bilirubin. So you would literally have to lyse like 4 liters of hemoglobin right now, like 4 liters of your blood, in order to overwhelm your liver and in order to cause indirect hyperbilirubinemia. So just because bilirubin levels are normal, you cannot rule out hemolysis. The more sensitive marker of hemolysis, because of this reason, is heptoglobin and LDH. So in this person with high LDH, low heptoglobin, and elevated reticulocyte count, all are overwhelmingly suggestive of active hemolytic anemia given the clinical context, right? So now the question becomes, why would someone have acute hemolytic anemia? One could think that this is a young person. Can they have some underlying hemoglobinopathy? Can they have like sickle cell, thalassemia, any RBC membrane defects? But you could imagine if that was the case, then we would have gotten the history, right? We have no history suggesting that this person has thalassemia trait, this person has sickle cell anemia, and patient's baseline hemoglobin was 10 to 11, right? So we can look back in the chart and make sure that they don't have underlying hemoglobinopathy, and what we are dealing with is not a crisis or kind of like exacerbation of that, but that should be lower on our differential, because we don't have a good enough history for underlying hemoglobinopathy, right? But down the line, one can obtain hemoglobin electrophoresis to confirm that hypothesis. So once you move beyond that, then what can cause active hemolytic anemia like this? Then in younger people, autoimmune hemolytic anemia is a bigger concern, right? That you can have your immune system, which is killing your red blood cells. And the ideal way to establish that would be obtaining a Coombs test. Because Coombs test in general, like apart from some very unique and rare scenarios, is very sensitive in picking out the hemolytic anemia driven by autoimmune nature, right? So we would get those Coombs tests and that will guide us where to move next. And finally, the third important point in hemolysis is what is going on in the metabolic milieu, that your electrolytes are fine. So sometimes very low electrolyte levels can alter the RBC membrane and can cause lysis. So we are not seeing that. Is anything from outside administered into your body? We know that there are so many drugs, so many substances which can cause hemolytic anemia if you have inherent susceptibility. Like, what if this person has G6PD deficiency and was exposed to any kind of oxidative stress in the form of food which people might eat or in the form of drugs which they might have received recently? We don't have any of those history, but again, we can go back to the bad side and ask them that, hey, have you tried any other products recently? Like any of the products, it could be cosmetic products, it could be the new kind of food they tried, because there can be oxidative species running around you in different environment, and that can go inside your body and can cause hemolysis, right? So in dramatic hemolysis, you need to know what is exogenous trigger. And then finally, there are some rare infections which can cause acute hemolytic anemia. But the classic example being malaria, right? But in our case, we don't have that story. We don't have fever. We don't have any infectious symptoms. So suspicion for that would be low. So to summarize, in order to start the workup, we should get the Coombs test to have a big branch point. Is it immune or non-immune? And if it is non-immune, then you start wondering that, okay, do they have underlying genetic predisposition? Do they have any new exogenous things going on? Or do they have any underlying infection? So that is how we can frame this. And what do you think, Dr. Singh? Any other thoughts you have?
Oh, yeah, no, nothing to add. That's absolutely wonderful. I think that you just took us through the whole landscape of anemia. We kind of moved away. We went straight to the bucket of hemolysis. And yeah, I think the first thing we have to do is we need a smear, and then we need Coombs test, and then we can go left or right. If negative, then we go to MAHAs, or we go to the RBC. Is there a defect in the membrane? You talked about spherocytosis, leptocytosis. Is the cytosol deficient in something? G6PD, pyruvate kinase deficiency. Is it the hemoglobin in the middle? Is it what do you call it? Sickle cell anemia, or could it be thalassemia? That's kind of how I think about it. But yeah, let's make a move to the next aliquot, asking for all those things, especially Coombs, and getting a peripheral smear. Back to you, Shreya.
Awesome, great discussion. I love the crude differential and the teaching about hemolytic anemia. So we were also thinking in the same line, like what has triggered hemolytic episode in this patient. So we did direct Coombs test, which was found to be normal. We also did PBS, which was normal. We also did hemoglobin electrophoresis to rule out all those sickle cell and thalassemia traits, and it was found to be normal. Cryoglobulin was also sent, which was normal. PNH flow cytometry was negative. We also did HIV and hepatitis B and C, and all were negative. Cold agglutinins were also negative. So I'm going to stop here and listen to what do you think now.
So a lot of these tests, so the Coombs test, we are not going to talk about. Warm is good and cold is IgM and so on, mycoplasma, mononucleosis and so on. So we kind of now deviate from that to now MAHAs. Unlikely, we're talking about DICHUS, TTP, and so on. Patient will be very sick, say with TTP. However, you can get hemolysis, and this could be a very low intensity hemolysis just with any trauma from valvulopathy, from high blood pressure, malignant hypertension, or hypertensive emergency, which is not the case here. Scleroderma, renal crisis, these kind of conditions can actually cause a lot of shear stress. LVADs could do that too. So I don't think we're in that domain at this point. So do we need to look at the RBC, the smear? Does it look abnormal? Usually we'll get spherocytes in autoimmune hemolytic anemia because you have a biconcave disc, and then you have the antibodies on the RBC, and then the neutrophils and so on will come and then gobble up like Pac-Man part of the RBC membrane. Then it goes from biconcave to a spherocyte. So you want to look at the RBC, you want to look at the cytosols, never look at pyruvate kinase, you want to look at G6PD. I think especially the chat mentioned, hey, and Kirtan mentioned earlier, we started a new medication, glipizide, 3 days ago. Could this be a medication-induced stress causing this hemolysis? So I think we need to look in that area. I don't think this is a mechanical shear stress. This is a enzymatic maybe stress. I don't think this is infection. This is not Bartonella or Leishmaniasis or babesiosis or malaria or anything like that. But what do you think, Kirtan?
Yeah, no, Dr. Singh, you're right that we got some data and we have to understand that, okay, how valid they are, right? So in general, as we said, that Coombs test, pretty reasonable test. And if hemolytic anemia was significant enough to cause this much drop in hemoglobin, you would see something on peripheral smear. You might see some spirocytes, you might see some agglutination depending on what kind of hemolytic anemia it is. You don't have any of those. So suspicion is low, and at least the basic workup like HIV, Hep B, C is negative. So would you pursue more autoimmune workup at this time, like ANA and all that stuff? Probably not, because you don't have enough evidence as such, right? And then the things with Dr. Singh was mentioned, like could this be TMA in some form, like pseudoderma renal crisis and stuff? So you could imagine that if your TMA is severe enough to cause this much drop in hemoglobin, you might expect some degree of platelet consumption as well, like things like DIC, TTP. We are not seeing any of those. And you would see cystocytes, right? So again, that is out of the bucket. And one might say that, oh, can you have intramedullary hemolysis? Like maybe RBCs are getting broken down in the bone marrow itself because of ineffective erythropoiesis. But again, in those scenarios, retic count is expected to be low because the bone marrow is not like able to perform well enough. And even in those scenarios, such dramatic decline would be a little bit unexpected. Like there are cases where you can have leukemias, lymphomas, HLH, MDS, whatnot in the bone marrow, which causes such hemolytic picture. But then it would be unusual for them to affect only one cell line and to present such dramatically. So even that rare bucket is gone. So we are still left with something is going on in the blood itself. Now, Shreya did mention a very important point that PNH flow cytometry was negative, which is very important to make sure that you don't miss that immune negative, like Coombs negative cause of hemolytic anemia, right? So once even that is gone, if you just think about the base rate, that we also obtain the hemoglobinopathies. Now, hemoglobinopathy panel is good at looking for thalassemia and sickle cell. It may not detect some other unique variants, which I will get to. So what are the two main possibilities? So I agree with Dr. Singh that the top suspicion given the base rate should be that maybe you have some enzyme deficiencies like G6PD or pyruvate kinase or any other glycolytic enzyme, which is impairing the RBC's metabolism. And maybe any trigger, it could be one of these drugs. If not one of these drugs, then as I said, that sometimes you never find out what is the trigger. It depends on what kind of food you ate, which maybe had some nitrites or nitrates, maybe you inhaled some gas, you had something which is causing G6PD deficiency to come up in this way, right? Second important point is that in terms of hemoglobin, apart from thalassemia and sickle cell, there is something known as unstable hemoglobins. So there are these unique varieties of hemoglobin which are so unstable that once they are in the RBCs, they will start lysing them. And it is very unusual form. And even methemoglobinemia is considered as one of those varieties. Sometimes methemoglobinemia presents as hemolytic anemia, not as the classic methemoglobinemia picture which we think about. So, and that is not captured on the standard hemoglobin electrophoresis. So I guess in this case, first thing is to get G6PD, get pyruvate kinase. If that is normal, then one might entertain the possibility of advanced hemoglobin sequencing to rule out this unstable hemoglobin markers. And that's what I was saying. Dr. Singh, any other rare thoughts which are crossing your mind?
I think that's wonderful. I think let's go to the G6PD or PK level and see what we have in store. Back to you, Shreya. Wonderful case, wonderful delivery of case and presentation. Thank you.
It was great discussion. So yeah, at this point, patient was transfused 1 unit of packed RBC and he was feeling a lot better. And his all drugs were stopped. And now hemoglobin is 9.4. So we went back and we did not know what's the diagnosis till now. So G6PD enzyme assay was sent, and so a lot of test here was not done in our hospital. We had to send it to the higher centers. So all the things were I have arranged it like this, but it didn't came back like this at that time. Some test came very later than the others. So G6PD also came back very late, and it was found to be low, 33 unit per DL. And diagnosis was sulfonylurea induced acute hemolytic anemia and G6PD deficiency. So if
Go ahead.
yeah, I'm sorry. Did I interrupt? Okay. Yeah. So before we hear your reflections and awesome teaching points, I would like to add some points from myself. So the one thing that Sudarshan mentioned and Hans mentioned in chat as well, the disproportion in HbA1c and fasting blood glucose, especially so this patient was not diagnosed G6PD before. He did not know anything about any test done before. And we asked about any hemolytic similar episodes that had happened in the past, post any trigger, anything like that. So there was no any such episodes. So we should at this time we were thinking that I went back and realized that the disproportionate HbA1c, because now patient 10 days back patient's HbA1c was very high, and now it's like 6. Like, how is possible? So, and fasting blood glucose was high as well, so the disproportion was already hinting that there is hemolytic anemia, but it was not a clear picture here, as you can see. And I also forgot to mention that we couldn't appreciate pallor for some reason. Even the hemoglobin was 6. I don't know, maybe we were not an expert, I don't know, but we couldn't appreciate the pallor, so I didn't mention it before. And another thing I wanted to mention is the drugs causing hemolysis in G6PD is very rare. So we wanted to repeatedly analyze and inquire about any hemolytic episodes for that reason as well. Because if he had that G6PD deficiency, why didn't he had any hemolytic episode post any infection? We don't eat fava beans here much, and G6PD is actually not very common here. So we were actually surprised. And another lesson learned was that before initiating any medication, we should always think that, especially those which can cause oxidative stress, we should always think of any undiagnosed G6PD deficiency possibility, especially even in areas where it is uncommon. So yeah, these are some points I wanted to include.
Amazing case, Shreya. What a journey if you think about it, from the beginning and dizziness and so on. But I think if you keep it simple, right? You keep your thinking simple, low blood pressure or orthostasis, dizziness, also give a glance to volume, and anemia can be a very powerful cause of that. The physical exam, I was thinking about this, but I forgot to mention, yeah, was there pallor, right? So the patient looking generally like he has pallor of skin, that has a good likelihood ratio for anemia, conjunctival pallor, and then also even capillary refill time, and then also palmar crease pallor. But here, sometimes the exam doesn't correlate. But very interesting story, remarkable presentation. Shreya, you presented every aliquot so professionally and so well. I appreciate you for bringing this case today. Any reflections, Keaton?
Yeah, no, Dr. Singh, like excellent case, like the way Shreya handled the aliquots, like the mystery was always there. And to the point of Shreya, like maybe they didn't miss anything. It's you could imagine that if your hemoglobin is lost acutely, usually pallor is something which takes the time to develop. Like imagine if you lose 2 liters of blood right now, probably you would not have pallor because it takes a while for like RBCs to reflect in the different organs and form the pallor. So I think that you guys didn't miss anything. It just was so fulminant, so fast. And also the point about hemoglobin I would mention is that A1C can be falsely high or falsely low, depending on what kind of process you're talking about. So when you are dealing with hemolytic anemia, you're talking about high RBC turnover, right? Which means that lifetime of RBCs is shortened from 120 days to like 5 days, right? So in these scenarios, what will happen is that there is not enough time for blood to get glycosylated by the sugar levels. So that is why you will have falsely low hemoglobin A1C, as it happened in this case. In other scenarios, when you have hyperproliferative anemia, like let's say anemia of chronic disease or anemia of iron deficiency, your RBC's half-life is not 120 days, it's 150 days maybe. So because of that, A1C has more time to like sugar has more time to glycosylate the hemoglobin. So whenever you have hyperproliferative anemia, your A1C is falsely high. And when you have hyperproliferative anemia, A1C is falsely low. So I think in this case, that is also a good point that A1C was low, suggestive of hyperproliferative anemia, as evidenced by high reticulocyte count as well, right? So that was a crucial clue as well. And I'm glad that your team astutely recognized the sulfonylureas component, and then you guys are able to swap in and patient with that. Thank you so much, Ria. So much gratitude for you to come back and present such an awesome case to us. Thank you to Dr. Singh for guiding the discussion. And now maybe I can pass the mic to Sahil to help us with teaching points, and Manaswini as well.
So, for an amazing case, Shreya, and amazing discussion. Shout out to Sire for his first teaching points. And here goes. So, first, we discussed our approach to orthostatic hypotension, whether it could be dysregulation in autonomic nervous system or it's a vascular issue, vasodilation versus volume in the vessel, which might be low, which could be due to some laxative or a diuretic they're taking, and is it a misdiagnosed hypotension, and so on. And then we also discussed how the volume depletion could be due to GI, skin, or kidney related, and the kidney being due polyuria or due to the diuretics. And considering the base rate of the disease, we were thinking about GI in the beginning. And then we segued into the drugs, where we spoke about pioglitazone, which is a PPAR gamma agonist, and it contributes to the volume overload. That could probably be an underlying vulnerability. And then we also saw that the likelihood ratio of the anemia might have been due to, we could see pallor in such a case, but in our patient we were not seeing it. And the temporality of the anemia was something that was so crucial, and the dramatic decline of hemoglobin was something that we saw, and that is something that we considered, because hemolytic anemia, like Dan mentioned, it could be hyperproliferative or hypoproliferative, and in hyper it could be HbA1c is low, and in hypo HbA1c would be high due to the increased and decreased RBC turnover. And eventually we also saw that since hemoglobin was undetectable, and physiologically it's rarely seen, and it could be seen in cirrhotic patients because hemoglobin, we do not release much hemoglobin. The cirrhotic patients don't make haptoglobin, my bad, and that's a strong marker for hemolysis. And we were considering active hemolytic anemia after ruling out sickle cell hemoglobinopathies, and based on the history. And it was important to get a Coombs test to identify whether if it was immune or not immune. And also check if there was a genetic predisposition like G6PD, exogenous substances like in our case, sulfonylurea, or it could be due to infections like malaria. Yeah, so those were the teaching points.
Thank you, Manaswini. And also, thank you, Sarah. Great points. You captured pretty much everything about this case. Thank you again, Kirtan. Great teaching for hemolysis, anemia, the whole chapter on this. And appreciate everybody for coming on and also sharing in the discussion and the chat. Have a great rest of your Tuesday, and hopefully everybody will be back tomorrow for another episode of VMR. Take care. Happy Tuesday. Bye.